and I will introduce Dr. Miyashita. He is an attending nephrologist at Seattle Children's and clinical professor at the University of Washington School of Medicine, Department of Pediatrics. His clinical interests within pediatric nephrology is hypertension, including the use of ambulatory blood pressure monitoring. His interests outside work include pretending to play some competitive sports, hiking in the Pacific Northwest, slurping some oysters and other seafood, and unofficially leading tours in Japan, including making sure folks stop in at the hot springs, which all sounds delightful. So, Dr. Miyashita, thanks so much for joining us this afternoon. I will turn it over to you.
All right, Erin, thanks so much for the kind introduction. And you, everybody in the audience, thank you for providing this opportunity for me to chat about my professional passion, which is hypertension in kids. I am one of, I believe, 3 or 4 providers within the division of nephrology that participate in our hypertension clinic. And I trained here in Seattle in late 2000s, and then I went away to be faculty at University of Pittsburgh and Children's Hospital Pittsburgh, and then I came back about 2 years ago, fall of 2022, and it's been great. It's been really great to come back to the Pacific Northwest and the city of Seattle. So, and please feel free to call me Yo. And as Erin said, I believe maybe a third, maybe halfway, and then 2/3 through this talk that there are some natural stopping points for take a breather, ask questions, and I do want this to be as much interactive as possible and not just me yapping away for an entire 60 minutes. So please feel free to ask any questions or maybe even clinical scenarios that you may have in your office that you want to run in by a nephrologist about blood pressure. So with that, this is my disclosure slide, and very sadly for my bank account or my wallet, I don't have any actual or even potential conflict of interest in regard to any of my work, including hypertension. So I'm going to just start out with a case just to put everybody in that clinical mindset before we dive into our topic. This may be a case that you may see a lot in your office. So let's say an asymptomatic 16-year-old male who presents in your office with elevated blood pressure readings. This has happened over the last several visits. Let's say with an average blood pressure of 144 or 92. And his height and weight parameters are 97th percentile for age. And when you take a little bit of family history, you note that father has hypertension and takes antihypertensive medications. So, potential things that you can consider as far as initial triage or management. Maybe in a multiple choice fashion, have the patient return to your office for a repeat blood pressure measurement in 3 to 6 months versus provide lifestyle counseling to increase physical activity and lower his dietary salt intake, and then potentially bring the same patient back for a remeasurement of blood pressure in about 6 months. Versus bring him back actually in a week and begin a diagnostic evaluation for stage 2 hypertension. And lastly, potentially call an inpatient hospital, including ours, for admission for immediate blood pressure reduction. And hopefully by end of our hour that you'll have a good idea of maybe what to do to manage a situation like this and others. So my objectives today are first to have a good understanding of why screening for hypertension is actually important in kids and adolescents. Number 2 would be to review the proper blood pressure assessment in your office. And third would be to review the appropriate triage and management when encountering a high blood pressure in your office, such as the one that we just reviewed in our case. and to review the proper recommendations for competitive sports participation, which I imagine is something that could come up in your practice, maybe on week-to-week basis, if not day-to-day. I do want to just first start off by going over this documentation. So, as you may know, U.S. or United States Preventative Service Task Force publishes their recommendation of a certain screening item to see if they're actually beneficial to our population. And since I think ever since I've been attending, which I think was 2009, that there's been actually two publications that's been discussed on this topic. And they've always concluded that there actually has not been enough evidence to recommend a routine blood pressure measurement as part of screening that we all do in pediatrics. And the Achilles heels of essentially blood pressure screening being worth doing is that there's never really been a longitudinal study to demonstrate that picking up a hypertensive children, then properly treating that person has a better cardiovascular outcome, potentially 3, 4, 5 decades later, compared to children who, were never screened and were never picked up to have hypertension. And as you can imagine, that's a very difficult study trying to execute. But without that, I guess I do kind of see at the point of the U.S. Pediatric Task Force to say that there's really insufficient evidence to really definitively state the balance of benefits and harm of screening for hypertension. However, there's been some studies, let's say more recently, say in the last 10 years or so, that have documented blood pressure tracking as well as target organ damage from high blood pressure. So the first graph that I want to pull your attention to is on the one on the left. And this comes from a long-term study follow-up in New Zealand, where they started checking blood pressure starting at age of 7 years old. And as you can see on the x-axis is age. And what this cohort underwent was blood pressure checks at age 7, 11, 18, 26, and 32. So a really nice follow-up time. And what this study demonstrated is that, as a child, let's say a 7-year-old or 11-year-old, that if you were in the normal blood pressure range at that time, then more than likely, as an adult in your 30s, early 30s, that you're going to remain in that normal blood pressure category, where if you were already, quote unquote, pre-hypertensive or hypertensive early in life, more than likely that you will actually be hypertensive as an early 30-year-old or early adult years. So this was a nice study that I think maybe been a first one to really demonstrate that the blood pressures do track throughout life. So again, the thinking is that why not trying to intervene early rather than later in the once you reach adults. The second study, which was published a couple years later, and this actually comes from the U.S., the state of Georgia, I believe it was the Georgia Stress and Heart cohort, where the follow-up was over 20 years. And this graph, similarly to New Zealand cohort, is that blood pressure do tend to track over time, starting at age of 10, and the study tracked through 30. But the additional finding was that they also assessed various hypertension or blood pressure target organ damage. So LVMI stands for left ventricular mass index, and higher it is, meaning that you have left ventricular hypertrophy, and that's a risk factor for a heart attack. And IMT stands for carotid intima media thickness, and that's a risk factor or prognostic marker for a stroke. And what this study was able to demonstrate is that not only you have blood pressure number tracking, but with higher levels of blood pressure levels, that you have higher LVMI and higher carotid intima media thickness, meaning that even at the age of 30, if you've been living with high blood pressure, you are already starting to see some target organ damages that would put you at high risk for cardiovascular events. Now, maybe some of you may be cynics. I don't want to be too judgmental, but I kind of doubt there are too many cynical pediatricians out there. It's just not in our personality. But let's pretend that one may be a cynic and say, hey, but all that stuff occurs way decades later. They leave my practice, so like, what do I care? But even in that kind of thinking, blood pressure actually may be affecting our patients. So this is a study that came out of investigators, I believe, in Rochester, New York, where they took 75 newly diagnosed and not yet treated hypertensive kids aged between 10 and 18, and this was all due to primary hypertension, and excluded all the secondary hypertension groups. And then they also found a nice control group, those with normal blood pressure that matched them for maternal education, gender, and their BMI. And they had them go through, take some performance exams that's been validated. And kids with newly diagnosed but yet treated hypertension had decreased performance throughout the spectrum of various things that we as pediatricians care a lot about, and those would be their ability to stay focused or attention, their ability to learn, their memory capacity, as well as fine motor dexterity. So even though one may say, hey, we're not going to see heart attacks or strokes in our patients, they may actually, their high blood pressure actually may be affecting their brains as we speak. So this is, a first great point. I don't know if anybody had any questions that up to this point, or I can move on to the next section.
There's nothing in the chat right now, and I don't see anyone's hand raised, so I think we're good.
Okay. So a lot of what we're going to go over today is, essentially the Bible of how we practice elevated blood pressure. And it comes from a big document that was published in 2017, the Clinical Practice Guideline for Screening for Management of High Blood Pressure in Children and in Adolescents. And this is actually a fifth version of Clinical Practice Guideline. The first one, I believe, came out maybe in the 60s or 70s. But this was actually a first one that was sponsored by American Academy of Pediatrics. As you can see, the first author of this is our former division head, Dr. Joseph Flynn, but he recently stepped down as division head, but he still remains very active in pediatric hypertension community, and maybe he may participate in the next CPG as well. But as you may all know, this being a AAP published guideline, it's composed of what are called key action statements that are evidence-based, and there's actually 30 of them. And in addition, there's 27 consensus expert opinions that are maybe not not evidence-based. And so it's a big document, and what I'm going to hopefully in the next 20 to 30 minutes or so is to go over the highlights that hopefully would be useful in your practice. So first, we'll start with who needs blood pressure screening, and if you're otherwise a healthy, non-obese child, the AAP guideline recommends to start screening blood pressure starting at the age of 3 years old, and just once a year. The previous guideline, I think, stated with every encounter, but with the updated one, it is now annually. Now, you may want to start screening for high blood pressure earlier than 3 years of age, and every clinic visit if your patients have these following condition, if they are obese or have chronic kidney disease, including any sort of anatomical congenital anomalies, diabetes, both type 1 and type 2, coarctation of aorta, even if it's been repaired, and obviously taking medications that are known to increase blood pressure, say like ADHD medications. If they have prematurity or significant NICU history, they are certainly at higher risk to have hypertension. And then any history of cancer or any form of transplantation, such as solid organ transplant, such as liver and kidney, or bone marrow transplant would also fall in this category of having more closer and more frequent blood pressure checks. Now, accurate blood pressure measurement is highly dependent on various various factors, and like many disciplines, I think fundamentals are really, really important in achieving accurate blood pressure measurements. I do want to spend some time discussing each factors, which are device selection, cuff size, and then placement, patient position, as well as timing. So first, let's start with device selection. I mean, obviously, the gold standard is to check manual auscultated blood pressure measurements that you may have in your clinic, such as the one that's on the left side of the screen. But more likely, for many convenience reasons, we tend to use oscillometric devices, such as the one that's more in the middle of the screen. And I don't think this is something that, unless you're like a blood pressure nerd, that you come across a fact like this. But the way that these oscillometric devices work, they actually do not measure or detect systolic or diastolic numbers. And what it actually does is it measures or it detects mean arterial pressure. Then depending on what device company the manufacturer or the blood pressure machines are manufactured by, they all have their certain mathematical algorithms. So depending on certain mean arterial pressure, it then creates or calculates a systolic number as well as a diastolic measurement. So what this means is that if you have a Dynamap and a Welch-Allyn and an Omron, that they actually may give you 3 separate, or I guess 6 separate blood pressure readings due to this fact. Now, there are advantages. Right? It's very easy to use. I may be able to, pick random non-medically trained person and teach that person to be able to use this monitor maybe in about 10 minutes and be able to have them check blood pressure. So it is easy to use. And also, we as human beings, this is a well-documented fact with old studies that when healthcare providers check manual blood pressures, we tend to pick more let's say easier numbers or cleaner numbers. So 100, 110, 120, or 40, 50, 60, those numbers actually occurred much more frequent than 46 or 42. So there is definitely an observer or digit preference biases. So when you use a machine, that factor gets taken away. But obviously there are some disadvantages, and as I alluded to, these machines don't actually measure systolic or diastolic blood pressures. And the normative data that I'm sure we have all loved and hate to use were all based on manual reading. So if you're comparing your oscillometric blood pressure readings to a normative table, there is a little bit of apples and oranges factor going on. So just you are aware of that. So now let's move on to talking about the proper cuff size and placement. So the placement, the blood pressure cuff, the middle of the blood pressure cuff should be halfway between your patient's shoulder joint to their elbow joint. And the way that you know that you're using a proper size cuff is the following. So, when you blow up the blood pressure cuff, there is a bladder within the cuff where the air enters. The length of that, which is represented by the segment C, that length should be somewhere between 80 to 100% of the arm circumference at that location that we just talked about. Now, what's unfortunate is that a lot of manufacturers will on the cuff indicate, from this point to this point is a proper size cuff, and unfortunately, a lot of times those things are not accurate. But as a provider in your office, or maybe you can also train the providers in your clinic, that once you are able to recognize what portion of the cuff is the bladder, and as long as it covers, either the entire circumference or close to the circumference of the arm, then you're using the proper size cuff. And this is important because, as you may know, using a too small a cuff will give you falsely elevated blood pressure measurements. And how about patient position? So, this diagram has a patient that's in an ideal position. So some of the key points are that, starting from the bottom, that your feet should be flat on the floor and not crossed. They should be sitting in a chair with the back supported. And then your arm that's having the blood pressure checked should be supported, maybe by a desk, or sometimes if I'm doing a manual blood pressure check, I may actually use my hand to hold their elbow to be supported. And the cuff, the middle of the cuff should really line up with the vertical level of your patient's heart. And there's actually a study that just came out recently, I think in the last month or so, that actually got picked up by the mass media, where the investigators of pediatric hypertension noted that the blood pressure, inaccurate blood pressures were taken when the arm was not supported. So the positioning is also really important, especially in your office where, we all have patients with different heights. Various tools may be useful to ensure that the feet are flat on the ground. And then, as we alluded to, timing is also very important. And this may be, I can understand that this would be a very difficult or challenging thing to do in your busy practices. But in an ideal scenario, patients should be resting for 5 minutes before the first measurement, and then maybe get a second reading taken maybe a minute later. And if you are, taking manual blood pressure measurements, perhaps some review of what we all learned in school many years ago, but potentially, it's a skill that we don't use that often on our day-to-day practice anymore. So just to review, that your stethoscope should be laying on the antecubital fossa and not, under the cuff. So what sometimes is tricky is that patients have large circumference arm, but the length of the arm may not be adequate, and that does provide, I think, the challenging situation where it seems like you may have to place your stethoscope under it, but that may also result in false or inaccurate readings. And just to review, the systolic blood pressure is defined by Krakow sound number 1, and as you start to loosen up the cuff, when you start hearing that heart sound, is defined as a systolic. And then when the Krakow sound or the heart sound starts to disappear, or it does disappear, then that's your diastolic measurement. So here's a suggested maybe a workflow of what to do in your clinic especially when you encounter elevated blood pressure. So hopefully many of your patients have blood pressure less than a 90th percentile, and that's normal, and you're done. But if you have an elevated reading, you want to repeat it 2 more times and maybe take an average of those 2 measurements. And if the average is, again, under 90th percentile, you're back into, a normal category and you're done. But if it's, again, above the 90th percentile, then you may want to then move on to auscultation, manual auscultation. And only then, if it's in the abnormal range, again, defined by 90th percentile, then you move on to defining their blood pressure in a more of a hypertensive range, or if that's not the case, then they can go back to normal. So, and here are the definitions. And I think one of the big updates for the 2017 guideline was that for adolescents, 13 years old and older, the numbers got very simple. It's the same definition as the adult. So just to quickly go over the adult guideline. So normal is anything less than 120/80. What was previously called pre-hypertension is now called elevated blood pressure, and that's 120/129, and anything less than 80. So there's actually no diastolic definition for elevated blood pressure. And then stage 1 is either you have a systolic measurement between 130 and 139, or diastolic of 80/89. And you always take the higher of the systolic versus diastolic. So if you have a patient that's 118/86, that patient has stage 1 hypertensive measurement. And then stage 2 is anything greater than 140 or 90. Again, whichever one is higher for the systolic versus diastolic. Now, what's still cumbersome that I think maybe gives headache to a lot of non-nephrologists is a definition of blood pressure between 1 and 13 years old. So now then we have to rely on the percentile, and it depends on the patient's sex, height, as well as age. So normal is defined by less than 90th percentile. Elevated blood pressure is between 90 and 95th percentile. Now, there are times that the 90th percentile exceeds the adult definition. So obviously then you want to have a more stringent criteria. So you want to use the 120/80 as a threshold. And similarly for stage 1 hypertension, the definition is anything greater than 95th percentile plus 12 millimeters of mercury. But again, if these numbers, if the percentile numbers exceed the adult guideline or the adult definition, then you want to use the adult numbers. And then stage 2, same idea. Any blood pressure that's greater than 95th percentile plus 12, or you see a number that's greater than 140/90, then you have a stage 2 hypertensive patient. So I think if there is maybe one slide to take a photo or get a copy of this from AAP guidelines to sort of put it in your office, this may be it, because it does provide, I think, a nice recommendation of what to do when you encounter a patient in these various categories. So obviously, if you're in a normal category, annual checkup is suffice. If you have an elevated measurement, this is somebody that you want to bring back the patient maybe in about 6 months while you're providing some lifestyle counseling. And if it's elevated again, 6 months from the initial onset of elevated blood pressure, you may want to then also check a lower extremity blood pressure, checking for coarctation of aorta. And if they come back 6 months after that, so for their 3rd visit, so a year from the initial elevated blood pressure incident, then you may want to consider a referral to someone like myself, the hypertension clinic, and maybe undergo ambulatory blood pressure monitoring, which we'll talk about a little bit. Stage 1 hypertension, that timeline sort of everything gets maybe moved up So the second measurement should occur in the 1 to 2 weeks. And the third measurement, which is, what nails the diagnosis of hypertension, should occur in the 3 months. Again, if it happens 3 times, then a referral should be made. And obviously providing counseling slash treatment recommendation should also take place with that third visit, with a ABPM to also take place. And then the stage 2 hypertension, these are the patients that you want to bring back to your office within a week for remeasurement, and potentially also, make a arrangement for ABPM. If for some reason, I know this doesn't happen as much with our group, hopefully maybe we'll get there someday, but for us to be able to see these patients within a week, then if that is possible, then we can see them within a week, and you don't necessarily need to bring them back to your office within a week. And just for reviewing a definition of what is hypertension in kids, it's abnormal, either greater than 95th percentile, or the adult number 130/80 or higher at 3 separate visits. Now, rare cases, there may be patients who may require immediate evaluation on the same day. And those are either, regardless of their degree of hypertension, if they have symptoms you think is your judgment is that it's from hypertension. And most often in kids, it's either headaches or some sort of CNS symptoms, whether it's mental status, seizures being more severe, and maybe vomiting being maybe not as severe. Regardless of the blood pressure, you do want them to come to immediate medical attention and potential intervention in the emergency room. If you're just otherwise they're asymptomatic, if their blood pressure is 30 millimeters of mercury above the 95th percentile, that's our pediatric definition for hypertension urgency. For adults and adolescents, the corresponding number or definition for hypertensive urgency is greater than 180/120. So these are the patients that you want to ship away right away. So here's, I guess, my second break point. I don't know if there are any questions in the chat or any hand being up. I'm happy to address them now.
Yeah, we have a few questions in the chat, so I will read those if you want to respond. I think most of them were coming in while you were sort of going over the positioning and method for reading blood pressure. First question is, for screening blood pressure at every visit for prematurity, is there a specific range of gestational age, or is this any infant born before 36 weeks gestation?
That's a great question. I don't know if our guidelines specifies, your question addresses your question. So I would say anything prior to 36 weeks. And I will also add, I think, just from my anecdotal experience, maybe even higher than 36 weeks, that it, for whatever reason they have complication and requires longer stay in the NICU, or those with small for gestational age or uterine growth retardation or restriction. Those are the patients that should also fall under that same category.
All righty. Next question. Any opinion on the automated wrist cuffs for home blood pressures for kids?
Oh, thanks for bringing that up. This does come up often, and I think I have a slide later about home blood pressure measurements. But for now, it is not part of the recommendation, and that this may change, but it's just not been validated, and most likely because it just hasn't been tested in the market. That's so. I guess what I will say from a hypertension specialist standpoint is that I wouldn't use it, but it may be something in the future, as especially, I'm kind of tangenting away from your question, but now we all have a lot of wearable devices, and will there be a time where those will be, clinically utilized, and I imagine so. And I think, some of the researchers in our group are actually, looking into these wearable devices. But for now, things like wrist cuff, I wouldn't necessarily recommend.
All righty. Next question. In a pediatric clinic, it can be very difficult to obtain all of the preferred positioning recommendations for blood pressure measurements. What advice do you have for the primary care provider left interpreting the BPs from these less ideal conditions?
Right. I mean, it's so easy for us in the ivory tower to say, this is what you should do. But yeah, I realize you guys are on the front line fighting this. If I'm understanding that question correctly, that in your office, maybe whether it's the chairs or exam chairs, they're not properly set up to, I have the ideal position for blood pressure. That's tough, and I don't know if there's a way to alter and use different, desk heights, chair heights, exam table heights to be able to obtain it. I mean, I would say, if you're getting normal blood pressure measurements in an non-ideal positions, then maybe it's okay. Just from from a realistic or practical standpoint. But if you are seeing a significant elevated blood pressure, then I think I think you're obligated, or my recommendation would be to raise exam tables or chairs, or use, bring in different height of chairs or tables to be able to achieve the ideal position. Because, as you can probably imagine, if we act upon a falsely elevated blood pressure, which, whether it's lab tests or sending somebody to a subspecialist, these are a lot of, I think, burden for the family, and certainly we don't want to put medication on these patients. So this is hard, and I guess my only sort of overlying statement may be, do the best that one's able to do.
Okay, and a similar-ish question, so you may have a similar or the same answer. This position seems fine for older children, but this position would be more difficult for young children.
Yeah, I'm not sure. I mean, this is something maybe after the talk, maybe we can go maybe more into specifics.
Okay, that sounds good. And then last question from this section, any logistics suggestions for pediatric AMBP? Where do we get it?
I will go with that.
Great. All right, that's everything for now. Thank you for the questions.
Right. Yeah, thank you. So now that, let's say you've avoided sending your patient to the emergency room, some of them maybe keep highlights to, as part of your clinic evaluation, maybe, taking a good history. And what I typically try to do is, are there any signs or symptoms of hypertension, making sure that it's not symptomatic hypertension, as well as maybe assess some comorbidities like sleep apnea. So I may get that story both from the patient themselves, as well as the parents or other household members. Rarely, I may be able to, pick up certain secondary hypertension associations, such as, hey, maybe they had a lot of, febrile UTIs as a young child, or if I place a stethoscope on their belly, I can hear what may sound like a brewery coming out of the renal artery. Those are things that may be picked up during your exam in your office. And obviously, for the most part, have an assessment of their nutrition and physical activity. We spoke about the NICU history and UTI as well. And for the family history, it seems like everybody has hypertension in their family. So what I really try to maybe hone in is like, are there any members who had early onset hypertension, maybe in their teens and 20s, as well as early cardiovascular events? And I sort of pick, value as 60 years old or earlier as early. And obviously, renal disease, diabetes, and obesity. And especially for the teens, I do also try to assess prescribed as well as unprescribed medication and substances. And this table, I think, provides maybe a quick, this is not a complete list, but some of the things that may be more common known to raise blood pressures. I've been learning more about more newer tobacco products and these pre-workout things that are just loaded with caffeine. So I think certainly they can contribute to high blood pressure. And certainly, I have in my non-hypertension nephrology practice, I prescribe a lot of calcineurin inhibitors as well as erythropoietin. So I may also be contributing to hypertension. So, just to simplify things, I think a lot of times nephrology's, street reputation that it's, kidneys are really hard, but in some way I think it's really easy because the differential diagnosis can be really short and simple. So when I approach a patient with abnormal blood pressure measurement, the three things that I always try to work through is this from white coat hypertension? Is this primary hypertension or secondary hypertension? And, and I think you can use your history and physical exam findings to build, index suspicions for each condition. And just so that you guys see a list, this is not something that you have to cement in your memory, but the differential diagnosis for secondary hypertension, I tend to like to go from head to going lower and certainly increase CNS pressure, cardiac cause could be coarctation or mid-aortic syndrome, something similar to coarctation, chronic lung disease, especially premature babies with chronic lung disease can also have an association with hypertension, kidney disease of various types, as well as kidney vascular disease can cause hypertension. And then, hormonal causes such as any catecholaminergic tumors, Cushing syndrome, hyperaldosteronism, or hyperthyroidism can cause hypertension. And then things like neurofibromatosis type 1, Turner syndrome, and monogenic hypertension are all genetic causes. And certainly, as we maybe alluded to, there are some iatrogenic causes of hypertension. And for our adolescents, we should not forget pregnancy, but I suspect you guys may be much better at this than myself. In the old days, I think it sounds like, maybe if you were practicing in the 1950s, if you had a hypertensive child, and that may have been like the case of the week. But unfortunately, that's not true anymore with obesity epidemic. So the 2017 guideline, guides us on like which kids do we really need to think about doing an in-depth secondary hypertension evaluation. So if your patient is 6 years or older, obese, there's a lot of history of primary hypertension in the family, you don't really, there are no yellow red flags that comes up on your history of physical exam taking, then you actually do not need to take or do an extensive evaluation. So, if your suspicion is, white coat hypertension, I think, one simple logic may say, hey, why don't we start checking home blood pressure? And at least, again, as of today, there's not as much validated normative data in children for home blood pressure measurements. In addition, a lot of the, manufacturers do not get their blood pressure monitors or cuffs validated for kids. So for these reasons, currently it's not recommended, but hopefully maybe someday that will change. And what the CPG does state is that home measurements may be a valid way to monitor once you start therapy, but maybe not necessarily for diagnosis purposes. Another option for white coat diagnosis may be, why not use a school nurse And unfortunately, this is not something that's really well studied, so we don't have a lot of evidence. Now, there are large-scale research studies that were about school blood pressure screening. One of the more famous ones was from Houston, Texas. So maybe for screening and not diagnostic purposes, school blood pressure measurements may be of some use. So what we end up using, at least in a maybe high resource country like the United States, we do send kids to a subspecialist to get a 24-hour ambulatory blood pressure monitoring. So we have, I believe, close to 50 monitors and available on our main campus, as well as our satellite clinics up in Everett, Federal Way, Olympia, as well as our outreach locations that are throughout the state of Washington and maybe Montana. So, it is, so to answer the question of, how do we get 24-hour ABPM, you do have to place a referral to our clinic. And the way that this works is that it automatically checks blood pressure every 20 minutes during awake hours and every 30 minutes during sleep hours, and then records them. And as you can see on even our pediatric patients, it is relatively portable. And with the use of ABPM, we use that with combination of office blood pressure and ambulatory blood pressure monitoring, and place them on either. We rarely have normal blood pressure because that means that they have normal office blood pressure. But if they have abnormal ABPM and abnormal office blood pressure, then they have what we call them sustained hypertension. And white coat is something that if they have totally, flat out normal ABPM, but elevated office BP. And then in converse, and we'll talk about this a little bit more, we also have patients that have what's called masked hypertension, meaning that they have normal office blood pressure, but they're actually truly hypertensive. And we can pick that up with ABPM. Now, as you may imagine, white coat hypertension is relatively common. Some of the more general pediatric studies that were done, the prevalence was somewhere between 1% to 7%, where if you have a patient that's been referred to a subspecialist, it's been described as high as 50% of the referred patients. Now, we used to think this was a totally benign condition, but now we're starting to think it could be a precursor for future sustained hypertension. So we, in our clinic, in our hypertension clinic, actually tend to follow up and do repeat ABPM somewhere between 1 to 2 years after their initial visit for this purpose. Again, so masked hypertension, it's not like we would, recommend do ABPM on every healthy, normal blood pressure patients. But what we do know is that masked hypertension is seen in higher rates in these high-risk populations. So, these are the patients that, high risk that are not rocket science. So diabetes, chronic kidney disease, coarctation of aorta that's been repaired, bone marrow transplant, solid organ transplantation, sickle cell anemia, and Turner syndrome. So they've all been documented to have higher than expected rates of masked hypertension. And I would say for what sort of labs should you maybe do in your clinic? I would say very basic urinalysis, basic metabolic panel, and if your patient is young, less than 6 years old, you may want to think about starting to get a kidney ultrasound, or you can leave a lot of it to us as well. But if you're seeing more school-aged patients and older, and you're suspecting primary hypertension, you may not necessarily look for the secondary hypertension, but evaluate them for the comorbidities of obesity, such as screening for diabetes, hyperlipidemia, fatty liver disease, and so forth, as well as sleep apnea. And then Some of the other tests I think really should be maybe reserved for subspecialists like us to maybe decide whether they are indicated, especially the renal vascular imaging, such as when to get Doppler versus CT or MRI angiogram. And I think maybe I'll just keep going for sake of time. So, moving right along to the last part, which is hypertension in competitive sports. I mean, obviously, we want these kids to be active, but there's been, some concern that trickled down to the pediatric patients because there have been some reports of sudden cardiovascular events in hypertensive adults. So what the CPG recommends is that, before you have them participate in competitive sports, the participation to assess their target organ effects and overall cardiovascular effects. And what I take away is that, maybe get an echocardiogram to make sure they don't have left ventricular hypertrophy, and maybe send a lipid panel to assess their lipid risk factors. And if they are stage 2 hypertensive patients, sometimes I have started medications maybe way earlier than I would, so that they can start playing their soccer season or whatever sports season that may be starting. The first line treatment is lifestyle modification, and as you guys may know, DASH diet, which is high in more whole foods, fresh food, high potassium and magnesium is what's recommended, and less of fatty foods, processed sugars, and salts. So again, very easy to, I guess, be said and then execute, and also to continue. We have a dietitian who's great to go over these things. But I think the efficacy, I think, is still very much a challenge. And for physical activity, what is recommended is 30 to 60-minute exercise sessions, 3 to 5 days a week. And again, I imagine all of us, including us adults who treat hypertension, can also follow these. But as you can imagine, life is busy, and these are hard to follow. And then on purpose, I didn't spend too much time on medication because I think, maybe eventually is the burden of hypertension becomes so big that the primary care pediatrician will also be prescribing medication, potentially. But this is just a quick table on the first 3, the calcium channel blocker, ACE inhibitors, angiotensin receptor blockers, are what I would maybe consider first-line treatment with their potential side effects, with the ACEs and ARBs. With teenage girls, you want to make sure that they're not pregnant, as well as you fully assess their risk for getting pregnant. And then beta blockers, what was new for the 2017 guideline is that it fell off the list of first-line treatments. And certainly, you don't want to necessarily use them for cross-country runners and track runners and soccer players and things like that, because they may actually lessen their performance levels to blocking their beta sympathetics. The treatment goal is, make them to have normal blood pressure. So reduce their systolic blood pressure or diastolic to below 90th percentile or less than 130/80 in adolescents. So here's a summary slide. Number 1, blood pressure measurement is important as part of your annual visits, annually starting at age of 3 or with every visit if there are risk factors. Number 2, blood pressure measurement timing and technique are important. And then use the degree of blood pressure elevation, potential symptoms, associated symptoms, the risk factors, extreme physical findings, and including substance exposures to the adolescents, to help you appropriately decide on the initial triage. But I think as we discussed, for the most cases, I think 24-hour ambulatory blood pressure monitoring is the recommended initial evaluation, and this should occur prior to any extensive laboratory or imaging investigation. And then last but not least, physical activity, including sports participation, should be encouraged once cardiovascular risks are assessed. So that is the end of my talk. I'm sorry, I probably ran a lot longer than I anticipated, but thank you for attending today. And if you have questions, comments, and feedbacks on how I can make this better, please let me know.
Awesome. Thank you so much. We do have, it looks like, one question in the chat. So if anyone else on the line has any more questions, you can feel free to type those in now or raise your hand and we can unmute you. For this question, it's a scenario. So I have obese pediatric patients with ASD, aggression, and complex psych disorders where it's impossible to get an accurate reading in clinic unless they are sedated, and we need to for medication monitoring. Is there any potential alternative? Risk cuts aren't great, but what about multiple readings at home and the patient is asleep? Is there any usefulness in something like that?
But I guess maybe I couldn't hear very well, but that it is difficult for maybe reliable blood pressure measurements. Is that?
Yeah, it sounds like it's a difficult situation with the patient, I imagine, moving quite a bit and being, difficult to be still. There's some psych issues.
Yeah.
And is there any alternative to get some good?
So, no, I think, I realize, I also encounter certain scenarios, and that's, ideally I would like to get an ABPM, but I can't. So these patients, I may, again, I'm fortunate maybe to practice in a setting where, in a high resource area, I might get an echo to, make sure that they don't have left ventricular hypertrophy. And if they do, these are the patients that would need medications. But yeah, so maybe an echo and spend, $3,000 because of these challenges.
Okay, thank you for some answers to some rather difficult questions. So we are at time, so I want to thank Yo for his talk and to all of our attendees today. I did put a link to the evaluation in the chat. I will also send that out via email either this afternoon or tomorrow morning. So we appreciate you completing that, and we hope to see you again soon. Have a great afternoon.